Welcome to the LowCarbUSA podcast, where we seek to inspire you to help us build this community. I'm Doug Reynolds.
And this is Pam Devine.
So tell me, Vyvyane, I heard from you and of you for the very first time when you got invited to one of our kind of group Facebook, low-carb Facebook groups. And you were just so passionate, and it really struck me. And the first thing I thought of was, I need to get her on my podcast, because that's what we really try to do, is get inspiration to people to consider and adopt this kind of lifestyle. But I never really heard how you got started, how you first found out about this. And so if you wouldn't mind just telling us your story, like how you found this, and then we can kind of build on that from there.
Yeah, so I trained in and I'm board certified in internal medicine. And right after training, very shortly after, I had a chance to work in an obesity practice. And, it was quite different from what I had been trained for. Because, normally you're very used to putting people on medications and seeing them decline over the years. And very shortly afterwards, I noticed that, oh, you know what? A lot of the times I'm taking away the medications, and that our patients are actually getting better. And this is pretty heady stuff, because I never thought it was possible. And in fact, I still have patients who come back to me and they say that, they went to see their PCP, they're off their insulin, and the PCP says, that's not possible. In my entire career, I've never seen that happen. So, I was very lucky to get exposed to it early. And I started to, work in the obesity field, and now I'm board certified in obesity medicine as well. But my own personal journey was also that I have a strong family history of diabetes, and just pretty much everyone, my mom's side, my dad's side, has had diabetes, high blood pressure, and things like that. And I went to my own doctor and got my A1C tested one year, and it was high. I believe it was 6.4. And I looked at her, she looked at me, and she says, it's not possible, don't worry about it. Just because I look this way, I didn't seem to have a weight issue. And she just looked at it and said, I can't explain it, don't worry about it. And it bugged me. It bugged me a lot, because I was like, that's not, 5.7, it's 6.4. Something is going on. And we're just not looking at it, because she's assuming that I should be healthy, given my age, given, my weight and so forth. And it bugged me a lot. And I started to dig a little bit more into, what might be going on. Around the same time, I had a friend who was trying to lose weight. And she asked me to be a buddy to her. She said she was going to go on Atkins. And I said, okay. So I looked it up and I said, okay, this is interesting. We'll give it a try. And I said, all right, we'll set a start date. I'm going to be your support here. We'll do it together. We started on a weekend. And by the end of the weekend, I had never felt better. All the symptoms that I had attributed in the past to irritable bowel syndrome, I always thought I would have to live with it for the rest of my life. It's just life. That's how it is. I didn't have any of those symptoms. And actually, I was really afraid to go back to carbs at that time. I just thought I never want to do that. Why didn't I know about this? And why didn't anyone tell me? And of course, that went on to, why aren't we telling our patients about this, right? And just slowly seeing the pieces come together. So, and from that time, I've just continued to try to teach myself, because unfortunately, in the medical community, there's not a lot of education on nutrition. There's not a lot of education on prevention. There's no focus on making sure our patients don't get sick, right? I mean, it ultimately is sick care that we're trained to do. So we just stand around, we kind of watch until the patient dies off the cliff. And then we all jump in and it's 5 scripts, you know, here's a medication, here's one for that one, here's for the symptoms of that one and the side effects of that one. And, you know, that's just how the training goes. And so as a result, most of the learning that I did, I had to do on my own.
Yeah, you know, that's, to me, that's the biggest thing is why do we have to wait until people get sick to address what they're eating so that they can get better again? Why don't we just feed people the right stuff from the beginning, and then most of them won't get sick in the first place? About it,
Doug, I mean, the whole system is set up, it's incentivized towards sickness, right? I mean, I always tell the story about how in ancient China, the emperor's physicians were paid to keep him healthy, right? And if the emperor got sick or died, off with the head. So if that were the incentive, right, you're not going to get paid, or you get you know, into trouble if your patients get sick. That's a whole different mindset completely. But now the incentives are all on managing the illness, right? We all get excited about managing the illness. Nobody talks about preventing the illness. So if the focus is on managing the illness, the training is on managing the illness, the whole system is incentivized towards sickness. And there's nobody's gonna make any money if you're not sick. That's
yeah, but then on top of that, managing the illness is all with medications. It's not about managing it by changing your lifestyle and what you eat and managing it that way, which is, as we have found, it's so much more effective.
If you change the lifestyle, you wouldn't really, you'd be treating the illness. See, that's not, okay, no, that's not the game. The game is managing it. So you move the deck chairs around on the Titanic. You move it from here to there, and you move it back, and it looks like you were doing something, right? We're moving around. We're not really getting any traction towards wellness, but hey.
Yeah. You mentioned something a bit earlier about the fact that your A1C was pretty high, but that outside of that, you looked healthy, and your doctor even assumed you were healthy because of that. And I think that there's so much of that going on where people, just because they don't put on weight, maybe they're not able to produce as much insulin as somebody else. So they don't put on, it's not pushing that fat into their fat cells, right? So they're not getting fat, but yet they may have sky high, in fact, they would have sky high blood glucose levels and stuff like that. And then all the metabolic issues that arise as a result of that. And no one addresses that. Everyone looks at these skinny people and says, hey, you're healthier than anything. And that's not the case.
No, you're absolutely right. Bingo, hit it on the head, because that was exactly what was happening with me. Most likely I was a little bit of the TOFI phenotype, where it's thin outside, fat on the inside. But secondly, I am of East Asian descent. I'm Chinese ethnicity. And so if you look at the differences in the insulin resistance in different ethnic groups, I was classic. So with East Asians, you see that they are actually very sensitive to insulin, but they can't produce a lot of insulin, right? It's quite the opposite from, let's say, African Americans. These are people in the normal sort of range, right? So with African Americans, even when they're not diabetic or not even trending towards that, they're making more insulin normally, right? And their insulin sensitivity is lower than, let's say, the Caucasian or the East Asian population. Now, I'm on the other end of the spectrum, where the insulin sensitivity is high, but we're not making very much insulin to begin with. And as we lose the insulin sensitivity, you just can't keep up. You know, the insulin is not being made. And so these people, you know, people like me, when we become diabetic, I mean, there's just basically no insulin made now in the pancreas. We look very much like the type 1s, right? So that was the other piece that was missing, that there are different ways that insulin resistance can expressed in different ethnic groups, and that is also should be part of the training. It's not. So we missed that. And as you know, we're all focused on glucose. So let's just fixate on the glucose, because that's a very, very, very late metric, right, to go wrong. And we'll wait 20 years while we're all trending in the wrong direction, because we're just looking at that one metric. So they weren't really looking at other metrics of my health.
Yeah, and I mean these the high glucose and high insulin levels in cases where people are able to produce a lot of insulin, both of those things I believe lead to all the inflammation and so many other chronic diseases. It's just it's incredible how many things it actually addresses. We just finished a virtual conference a couple of weeks ago, and Amy Berger was talking. Did one of the talks, and she was saying, like, you sound like a kook. Like, every time somebody tells you there's something wrong with them, you say, why don't you try keto? You know, I've got PCOS, I've got this, whatever your conditions are, why don't you try keto? And the fascinating part of it is that it really does help with so many things. You know, that underlying insulin resistance actually manifests itself in a ton of different conditions, depending, numerous conditions in some people and maybe only one in others, but different people respond differently to the underlying problem. So
yeah, you sound, if you don't know the pathophysiology, and that is the problem, right? So we do end up sounding like kooks. But if we just all sat down and looked at the pathophysiology and were a bit more open-minded, I think that it would be a different story.
Yeah, and I think so much of it actually can be explained if you look back to the biochemistry and the biology. It all totally makes sense, and yet, if there's not a randomized control trial that categorically shows that something's a certain way, then people tend to brush it off. But a lot of the times it's really difficult, and sometimes not even ethically cool to run, randomized control trials for a lot of things. But if you go back to the biology and the biochemistry, you can actually find the answers there without even doing the trials in the first place. So, one of the things that kind of is becoming really important to me is trying to reach the impoverished communities, and in our case, the African American communities as well. I had Tony Hampton on this conference that we've just done, and I had a long conversation with him. He's an African American doctor who's in this space and active. And I was talking to him and the people before that, trying to understand why we didn't have many and sometimes any African American attendees at our events. And, one person actually suggested to me, well, hey, you don't have any African American speakers, which makes a lot of sense when you think about it. But at the same time, until I came across Tony, I didn't know of any. And so it's been very cool to start these conversations with him. And we even had a guy called Gurpreet Pada on, Dr. Gurpreet Pada, and he's also working hugely with the impoverished communities in his area. And so we're trying to find ways to, under this new Society of Metabolic Health Practitioners, this nonprofit that we're starting now, there's going to be a committee under there to try to strategize how we can reach these poorer communities. And I seem to remember a little bit about you being involved with projects like that in one of the meetings that we had. Was I?
Oh, yeah, we have, so ever since I started out as my own private practice here at Transform Alliance for Health, we've always made sure that we've reached out to different communities, right? So I've had patients, for example, invite me to their churches. So I've done a lot of talks at, let's say, Haitian churches, I've done a lot of talks in the African American community. And this year in January, we had our first MLK seminar on cardiometabolic health. And we will continue that tradition in the coming year. So I'm really excited because I'm already starting to prepare for that seminar and prepare the materials for that seminar. And I find that a lot of my patients who are, African Americans have asked me if I would speak, and I've gone into their communities. I've done now, arrange Zoom conferences so that I can speak to their family members, to other people, in their neighborhoods, because they want to know what it is that is making their friend, their loved one healthier. And I will say, actually, it's a very, very good community to reach out to in terms of you don't need to do a lot to convince them, because they've been completely let down by the medical system as it is. And, there's very little trust in the traditional medical system, and rightly so, because they really have been shortchanged in so many ways and undermined in so many ways, for so long. So they're really open and looking for something that is going to help them, that is practical, that is something they can bring not only to themselves, but their kids, right? So I find that the reception I get is very warm. I find that I had, for example, a patient of mine tell me, I sat for an hour listening to you talk, and you made more sense than going to my doctors for the last 8 years and getting sicker every year. She said, I just decided, no, I'm going to go see her because she made more sense in 1 hour than the 8 years I've had with my other doctors. And so I think there's an openness there. There's a willingness to learn. And it's really very rewarding to work with different groups, different ethnicities, because I find that it tends to be ignored in mainstream medicine anyway, right? We have these great disparities, and that's something that I've always been very passionate about.
Well, that's very cool. Probably in the next month or two, this society that we're creating is going to launch officially. And as I mentioned, one of the initial committees that we're going to create is one specifically to look at addressing these poorer and what's the word? Less enlightened communities. I think nobody's been reaching out to them, right?
I think they're more enlightened because they don't really trust the current system, and I'm like, yeah, there's a good reason. I actually think that they're just looking for avenues where they can learn and have access to practitioners who are, practicing in a totally different way. And the mainstream hasn't opened their doors. I think that if and when we do, we're going to find that many people are very interested.
Okay, yeah, no, totally. So what I'm hoping is that I'm inviting you here right now in public so that you can't back down. But to be a part of that initial committee, probably Tony Hampton and Gapriet and yourself can be the kind of the core group of that, and hopefully we can do some good stuff.
I would be thrilled. I'd be very honored. I mean, those are the communities that are dear to my heart. I want to work with different ethnic groups. I want to work with Native American groups. So these are things that are, I think about this every day. So. Well,
that's brilliant. I look forward to working with you further on this. And thank you very much for doing this and being a part of the solution, as I like to say to a lot of people. And we'll speak again soon. Thank you so much. You've been listening to an episode of the LowCarbUSA podcast. You can support us on Patreon at patreon.com/LowCarbUSA.